No, we don't have time. Thank you very much. Okay. The next presentation, Dr. Salmanton-García. Nirmatrelvir, ritonavir, COVID-19 patients with haematological malignancies, a report from the EPICOVIDEHA registry.
Thank you very much. Yeah, I'm Jon Salmanton-García, also from the University of Cologne in Germany. And first of all, thank you very much for being here this early today. These are my disclosures and also the disclosures of the registry itself. And well, first of all, after the after the COVID-19 vaccine was declared, vaccines were the first, not really treatment, but preventive alternative or method that was released. And basically it was to prevent hospitalization and mortality. However, as Oliver just mentioned before, in patients with hematological malignancies, we are facing, or we have to face, an impaired immune system, and therefore they don't work exactly the same, and we need additional efforts to keep them safe and eventually to treat them when they are in a COVID-19 episode. For that, currently what we have are antivirals and monoclonal antibodies, as we have seen in previous presentations. In the case of the antivirals, we have mainly three: molnupiravir, nirmatrelvir, ritonavir, and remdesivir. And from these two, molnupiravir and nirmatrelvir, ritonavir, are of oral administration. In the case of the three antivirals, the main goal is to reduce the hospitalization, severe infection, and eventually also the mortality. In these results I will present today, we obtain all the data from the EPICOVIDEHA registry, which is an online registry for patients with active hematological malignancy within the last 5 years before COVID-19 diagnosis. They are always adult patients and they must have a laboratory-based diagnosis, either PCR or antigen test. And specifically for this publication, we did an export with all the cases from 2022. We distributed the patients in 3 treatment groups. The first one were all the patients that did not receive any treatment for SARS-CoV-2 or the one that received non-targeted treatment, like for example, corticosteroids or plasma. The second one were patients receiving nirmatrelvir, ritonavir, and then patients receiving SARS-CoV-2 targeted drugs that were not nirmatrelvir, ritonavir. We did 2 things. First, we compare patients and we wanted to see which was the reason or what was behind giving a patient nirmatrelvir, ritonavir. And for that, we did a propensity score based matching, and we did the matching in different variables, in total of 5: sex, age, severity of the baseline malignancy, type of the baseline malignancy, and origin continent. The origin continent was Europe for the matching, because all the patients treated with nirmatrelvir, ritonavir registered in EPICOVIDEHA were from this continent. And now we can see the characteristics of the patients. Most of them were male, around 60%, a median age of 66, 67 years old, and the main underlying condition beyond the malignancy was the chronic cardiopathy. Furthermore, we have chronic pulmonary disease and smoking history, which might vary depending on the treatment group, but in any case, they never reach the statistical significant difference. And then regarding the baseline malignancy, we can see how the major malignancies were lymphomas and leukemias. Regarding the status of the malignancy when COVID-19 was diagnosed, this we have seen in other EPICOVIDEHA results. We have done in many different aspects, like allogeneic HSCT, molnupiravir versus nirmatrelvir, etc. You can check them all in PubMed. And we saw that the control malignancy was reported from the 60% of the patients. No patient or no big number of patients had neutropenia. And regarding lymphocytes at COVID-19 onset, we could see how patients treated with targeted drugs that were not Nirmatrelvir, ritonavir, were those at a higher proportion of lymphopenia, and in this case, this was statistically significant. Regarding the vaccination, patients receiving targeted drugs that were not molnupiravir, ritonavir, they had the highest proportion of non-being vaccinated, 1/4. And at the same time, the patients with Nirmatrelvir, ritonavir were those with the highest proportion of a 4th vaccine dose, almost 15%. Regarding the symptoms at onset, we could see how the patients treated with Nirmatrelvir, ritonavir, and also the patients with no treatment or non-directed treatment were more frequently having only extrapulmonary symptoms, or they were being diagnosed because of a screening process. And finally, one of the main results of our research, the mortality rate at day 30 since COVID-19 diagnosis. We could see how it was of 11% in patients with directed drugs other than Nirmatrelvir, ritonavir, 2% in patients with Nirmatrelvir, ritonavir, and 6% in patients with no treatment or non-directed treatment. And the first question was, okay, what makes or how does a patient need to be to get Nirmatrelvir, ritonavir? In the case of haematological patients, of course. We saw two different results. First of all, with a sign of a minus, we had patients with chronic pulmonary disease and patients with obesity. These two groups were less likely to receive Nirmatrelvir, ritonavir. On the contrary, patients with the plus sign, extrapulmonary patients or patients with extrapulmonary symptoms and patients with a 4th vaccine dose were more likely to receive Nirmatrelvir, ritonavir. And we also found this, or the results from this slide, pretty interesting because, as I mentioned at the beginning, Nirmatrelvir, ritonavir is orally administered. So basically, we expect that the patients don't really need to end up in the hospital. And in this case, we can see how, depending on the country, this might be different. And even in a, one could say, quite homogeneous society as the European one. We had two countries where almost no patient or no patient at all, like France and Italy, end up in the hospital in any of the moment of the COVID-19 episode. However, in Spain, Belgium, and also Austria, Serbia, and Germany, the patients, most of the patients, and in the case of Austria, Germany, and Serbia, they end up at a certain point in the hospital during the COVID-19 episode. So here we really have, well, room for probably an additional research on, okay, what's happening and why is that difference, the use or even the results after Nirmatrelvir, ritonavir, depending on the country. And the second question was, okay, we have identified which patients are receiving Nirmatrelvir, ritonavir. What happens, which are the ones that are at higher risk for mortality? Well, you don't see any star, any yellow, any sign. Basically, we didn't manage to identify any factor associated to mortality in this patient group. Nevertheless, I want to remind you that the mortality rate was 2%. So basically, the mortality rate was that low in this type of patients in this analysis that we didn't manage to find any reason associated to mortality, because even if we see here how chronic cardiopathy is close to be significant, also diabetes mellitus, even active malignancy, but they never reached that significance in the univariable model. We put them in the multivariable model, but still nothing significant. So definitely larger samples are necessary, and then, well, perhaps one could find which are the factors associated to mortality in hematological patients receiving Nirmatrelvir, ritonavir. Here we have a graphic representation with a Kaplan-Meier survival plot of the survival probability depending on the 3 treatment different groups I mentioned. And we can see how it's significant, the difference between Nirmatrelvir, ritonavir and patients receiving other targeted drugs that are not Nirmatrelvir, ritonavir. And with this, the take-home message is that first, the patients with extrapulmonary symptoms at onset and also the patients with a second vaccine dose booster are more likely to get Nirmatrelvir, ritonavir in hematological malignancy. And on the contrary, patients with chronic pulmonary disease and obesity are less likely. Additionally, we could see how the mortality rate between patients with Nirmatrelvir, ritonavir and other options was statistically significant, and in Nirmatrelvir, ritonavir was lowest. And what I mentioned in the last slides, definitely further analysis are needed in order to determine which factors can be associated with mortality in patients receiving Nirmatrelvir, ritonavir. And last but not least, I would like to thank all the contributors to the EPICOVIDEHA registry for this publication, because actually it was recently published in eClinical Medicine. So in case you want to read all the details, feel free to visit the manuscript online, and also to all the members of EPICOVIDEHA registry. Thank you very much.
Thank you. Any question?
I just wanted to give a chance so that people who could ask questions. Your different rate of hospitalization within European countries was very intriguing. And do you have work data? What exactly is the underlying reason that you would think of?
We don't have data because we didn't collect the data. We have collected information because we saw, okay, this is strange, because the purpose of Nirmatrelvir, ritonavir, it's clear. And we could see that the access to Nirmatrelvir, ritonavir, it was not pretty straightforward always. There were some restrictions, and also we could see, we didn't include it, but in the publication it does appear, that the median time of administration of Nirmatrelvir, ritonavir was 4 days, when the recommendation is 5 days. So we could see how the different options were restrictions in the, or not restrictions, but limitation in the access to the drug. Also, depending on the country, the access was not guaranteed exactly in the same way. And that's why I mentioned that probably there is room for a specific publication on why the distribution of the ambulatory administration of Nirmatrelvir, ritonavir was different between the different European countries. Because we could see that, well, there was a whole, or there could be a whole history behind those results. Thank you very much for the question.
Only very fast question. In this cohort, are there the patients receiving a prophylaxis with Ixazevimab and Silgavimab? Yeah,
there are some. Actually, we published recently a manuscript on that. So if you check in PubMed for EPICOVIDEHA, it will appear, well, like in the most recent ones. And the thing is that it was very reduced, to be honest. I mean, the sample was small. It was around 50 patients. So yeah, I mean, if we look very in detail, we cannot really draw very, very significant differences or meaning. But nevertheless, specifically about the hematological patients with Ebushel, the patients were benefiting. I mean, it was good for the patients and for the outcome, and the mortality was really, really low after the administration of Ebushel. Yeah.
Thank you.
Thank you very much for the questions.